Good evening, everybody. It's pleasure to be with you today once again with actually 6 challenging cases. Though in the brochure we have put only 5, and it's pleasure to have Professor Athol Wells, Bhavin sir, Murli sir, Mithun, Ritu madam, Prabhu Desai sir, and the presenters for today are Alpa Dalal madam, Vinod from SRMC Chennai, myself, and Rajan sir. We have got Dr. Lakshmikant and Dr. Sanjay Amin as a guest. Sanjay Amin sir is a senior rheumatologist and Lakshmikant is a pulmonologist who is also going to contribute in one of the cases. And we'll start with the case 1 that is going to be presented by Dr. Alpa Dalal. One second. I'll share, ma'am. 1 second. Yeah, over to you, ma'am.
So, hello everyone, and I'm Dr. Alpa Dalal from Jupiter Hospital. I presented this case in October, and Professor Wells and Dr. Sujit Rajan were also there. In fact, Dr. Sujit has also seen this patient. So I'll quickly go through the case again. She's a 44-year-old lady, married, homemaker with 2 children. No comorbidities. First presentation was in April 2021 with grade 2 dyspnea since 2019. And typically she used to complain of chest pain and heaviness intermittently. HRCT done was reported to be sarcoidosis. ACE levels were normal. CTD workup was negative. She showed good response to steroids. And from 21 to December 23, she was on azathioprine 100 milligram per day, prednisolone 5 milligram per day, and we had put her on ICS LABA. And she was lost to follow-up for 2 years. But in between, she received multiple courses of oral steroid for her worsening symptoms. So she came back to us in December 23 with similar complaints of retrosternal pain, palpitation, and grade 2 breathlessness. And she was on azathioprine that time with prednisolone 5 milligram. A serial PFT did show drop in the lung volumes. At this point, she was started on methotrexate 15 milligram per week and continued with prednisolone 5 milligram per day. And symptoms of chest pain and breathlessness were a little better, but every time we used to taper the steroid, her symptoms would increase. And we repeated HRCT chest in October 24. And that was the time we had the MDM. And you can see here from December 21 to September 24, there has been a drop in her FEC. From 1.5 to the last one in September 24 was 1.13. So almost about 400 ml of drop in FPC. And DLCO also dropped from 58% to 49% in September. KCO is okay, but DLCO is showing the drop. And even TLC is showing significant drop from 3.77 to 1.94. So between May to September 24, there was not much difference, but over the years, you can see that there's significant drop in FPC and total lung capacity. Next. 6-minute walk test, which was done in October, there wasn't much desaturation. Her walk distance was 350. That was 58% of predicted. Next. Okay, so that time the question put for the MDM was, should we do bronchoscopy, BAL, TBLB? What are the treatment options? Whether to restart steroids, and should we start antifibrotics? And what was the long-term prognosis? So it was decided at that point in the group with inputs from Professor Wells and Dr. Sujit and others that we should go ahead and do BAL and TBLB. And we decided to increase the dose of methotrexate from 15 milligram per week to 20 milligram per week, and with a short-term increase in the dose of steroids. And since her PFTs were stable from May 24 to September 24, at that point, we decided to defer starting her on antifibrotics. And so that was the discussion. So now the follow-up after October 24, what has been done? Next slide. So we did her PET scan, and we would like to discuss the PET scan. Dr. Bhavin, do you have the PET images? So before going ahead with
I
the
have some images, only the fused ones, and
okay.
they just show small lymph nodes, one subcarinal with a little uptake. So maybe I'll show it when we're showing all the other images, if at all. I mean, there's nothing spectacular about the images. So
Okay. Yes. Going back to the presentation. Yes. So we did the transbronchial biopsy, and we also did EBUS to get to biopsy the previous slide, Dr. Smita.
There is no
So we
previous
did
PET scan, right, Alpa? There's no previous.
no,
Okay.
no. So we were pretty sure of the
Sure.
diagnosis of sarcoid, and yeah, this was just because we decided to biopsy, so we did the
Sure,
PET
sure.
scan. So EBUS and TBLB, it confirmed the histopath confirmed non-necrotizing granulomas. So that was confirmatory of sarcoidosis. And at this point, we increased the dose of methotrexate, and the steroid was increased and tapered ultimately to 5 milligram per day. And beyond that, we could not taper, and we did not start antifibrotics. Next. So in March 25, she got admitted with increased cough and a significant increase in dyspnea. It was grade 3, and she was very tachypneic. Her oxygen saturation was maintained, but her respiratory rate at rest was around 30-32. And at this point, we repeated the HRCT. And Bhavin, would you like to discuss the HRCT now?
yeah, I'll do that. One second. So I need the sharing to, yeah. So if you can see this, that's the September CT. We have the PET here, and as I said, I'll just quickly run through the PET. It just shows these mildly enlarged, mildly active lymph nodes. I think the subcarinal would have measured about 16, 17 mm in short axis. A few mildly enlarged hilar lymph nodes, and then really nothing else of consequence. So it fits in with sarcoid as a diagnosis.
What
And
was
then
the
here
SUV max, Bhavin, on the
would have
maximum?
been about 2, 3. These are fused images.
Okay. Okay.
But that doesn't really matter. It's not, but they're minimally active. Let's put it that way.
Sure. Sure.
So these are the two CTs, and if I just run through them here, if we start from the top, we've got these fissural nodules. We have an axial distribution of the reticular opacities. And both the scans pretty much look the same, but there is definite progression on the current study. And if you look at, any of these secondary pulmonary lobules, let's take this one. This is nice and black here, and it's filling in here. And the concern really is that it's the fibrosis that is progressing, not just the ground glass. And so, which would mean that in a span of about 7 months, there is fibrotic disease progression. The rest of the things, the pattern being the same, and there's no super added complication. The MPA diameter also appears to have kind of increased. I'm not sure if the pH had progressed or not, but this is about 29 and this is about 27. So that's reasonably significant,
Echo
a 2
didn't show
centimeter
any
increase.
progression of pH.
Yeah, that's fine. I mean, echo is also a very crude way, but whatever. So, but that's pretty much it. So this is where we are.
Yeah.
Is she on antifibrotics, Alpa?
Yeah, so we started her on antifibrotic. So we hospitalized her, and then we had to give her IV steroids, methylprednisolone 40 milligram once a day. Antifibrotics were added at this point. 2D echo did pulmonary pressures were 25. She had a lot of cough, so we had done a serum galactomannan level, so that was 1.97. So we consulted an infectious disease specialist, so he decided, I mean, he advised to start the patient on voriconazole. So that was started. And we also did the pulmonary function test. That was done in February. This was just a month before her exacerbation. Can I have next slide, Dr. Asmita? And you can see this was her regular follow-up. So compared to September 24, the FVCA has not changed much. The DLCO is also same, and even the total lung capacity is same. And at this point, she was doing pretty okay clinically also.
Can I draw your attention to something that really stands out on the lung function sheet? If you bring it back.
Yeah.
And the KCO is rising 70, 88, 82, 107, 121, 127. So clearly some of the lung volume reduction is extrapulmonic, really. Not all of it is, because the DLCO has fallen. So I think in a way we might be a bit misled by focusing on the lung volumes to looking at the severity of progression. I suspect she may be producing a submaximal effort. Perhaps she's not feeling well. Perhaps she's struggling with some of the technique. But for whatever reason, the KCO is nearly doubled. 70 up to 127 in parallel with reductions in volumes. Now, go on to weave all this together, but I would want to include that in the weaving together.
That's it.
So the previous slide, Dr. Asmita.
So, Dr. Alpa, what has happened to the predicted values? They seem all over the place, you know. So you will see the absolute values on both the FVC and the KCO have come down. So the FVC has come from 1.5 to 1.4.
You've changed your units. So there are two sets of units for DLCO and KCO, and they're about 2.5-fold difference. So what's happened is you've moved from one set of units, which was used up to May 2022, to the new set of units.
No, I get that, Professor. The problem is, you know, when you have this kind of reduction, why should the KCO go up? I didn't quite get your explanation.
Oh, okay. It's very simple. KCO rises when there's extrapulmonic restriction as a cause of lung volumes. Because the extrapulmonic restriction, you put a cuirass on somebody and they can't produce the same lung volumes, but their blood volume is just the same. So the blood volume is concentrated in a lower lung volume. So the carbon monoxide uptake per unit of lung volume rises. So it's a classical pattern. You see a fall in volumes, you look at the KCO. If with extrapulmonic restriction, the TLC drops by 50%, the KCO will rise by 75%. And so this is a signature of extrapulmonic restriction. Now, that might be muscle weakness. It might be that she's just feeling too sick to complete proper lung volumes. It might be pleural, which doesn't apply in her case. You can go through a list. I'm not denying this progression. Bhavin's pointed it out. The DLCO is surprisingly unaffected by extrapulmonic restriction. It should, in principle, stay the same, but you get a bit of a mismatch, so you do drop the DLCO a bit. But I think there's more DLCO drop overall, although I have to say that the DLCO hasn't changed between December 2022 and 2025. So I think extrapulmonic restriction may be a big deal here. It doesn't alter the fact that Bhavin can see worsening on the CT scan. And I think it's a slightly unusual scenario. Bhavin, you'd say the nodules are going with generally inflammatory reversible disease. and you're seeing additional fibrosis. But to get that in sarcoid on this therapy is a little unusual. We do see it with UIP when that supervenes, and honeycombing of any kind is a shorthand for likely UIP if you go to a biopsy, but we haven't got honeycombing. We haven't got anything looking like UIP. So it's a slightly unusual scenario. The next thing is that the PET scan is not, as I understand it, showing major signal in the lungs. So it's not like we're getting a message that there's insufficient suppression of sarcoid activity in the lungs. So that also is a little unusual. And so weighing up what might be done next, I suspect that you are wise now to go to antifibrotic therapy simply because you have the phenomenon of more fibrosis on a scan, in spite of therapies that have effectively suppressed sarcoid activity. Now, whether there might be some aspiration, which is supervening, which is adding to fibrosis in those lung regions, that's a wild guess. You're trying to think of pathways that are not usual sarcoid pathways. But the fact is, if you are seeing more fibrosis in spite of management, then I think that it is not unreasonable to go to nintedanib. And by the way, I think the extrapulmonic restriction explaining the things probably explains why she's still got a relatively good 6-minute walk distance with relatively little desaturation. If that was really progression of ILD to that extent on those volumes, I would have been very surprised that she didn't get more signal on a 6-minute walk test. So it is complex, but I can't really come up with a better suggestion except to say critical to minimize steroid and get her off even her residual steroid once you've established stability.
Did she improve significantly with steroid, Alpa?
She did. So even before antifibrotic was just 4-5 days on, but the moment we started her on methylprednisolone 40 milligram OD, and then for 3 days we had given it 40 milligram BD, there was significant improvement in her symptoms, in her tachypnea. So these two, and in fact, she came for follow-up in the OPD, and even 6-minute walk distance has increased by almost 150 meters.
Yeah,
would you consider such a patient as all for a TNF alpha inhibitor?
Yes, I would, but I think the other thing to say is that she's apparently on quite a high dose of methotrexate and apparently taking steroid, and these things aren't working when they usually do. But when you actually can see you're giving her steroid by injection, she does get a striking response. So I would really want to know if she's actually taking her drugs. Because there's a discordance here.
Yeah.
I mean, sarcoid of this type with a lot of nodular infiltration on a scan ought to be responding to the sort of therapies she's had.
So do you all do serum prednisolone or methotrexate levels in the UK?
Talk to her first, and just with a bit of empathy, I think try to understand if she's got reservations about treatments or she can't access treatments for some reason. I think you've got to be a little bit suspicious, because I would have expected with the amount of nodular infiltration that the treatments you're using really should be abolishing that. A consistent finding on serial CT. You can't, in sarcoid, interpret ground glass. That can be fibrotic abnormalities, and you won't always have traction. You can't do that. But the one finding that seems to be robust on serial CT is if you've got nodules, they're almost always reversible. And we're not seeing that. And yet she's having quite a lot of treatment, which should be reversing them. So I think you've got to go back to the question is whether your intention to treat is turning into taking the drugs.
Yeah. She's complying, Alpa? You think she was complying well before the exacerbation?
Yeah, well compliant. In fact, in February 25 PFT that I shared, it was almost same as September 24. So had she not been compliant, I think we would have seen the drop in her regular follow-up PFT. So symptoms were also well controlled, and PFT also did show stability.
I'm having major trouble interpreting the serial lung function. With ILD, if you get a major fall in volumes, the DLCO should drop in parallel. Other things can cause DLCO to drop, but the DLCO should drop in parallel. But her DLCO is completely unchanged from the second reading to the final reading. The volumes are going down, and the signature is this is extrapulmonic restriction for whatever reason. So I don't think you can look at the volumes and say, I know this is ILD progression, basically. If it was, the DLCO should be dropping, which it isn't after the second reading. Not at all, actually, and over a period of some years. So I think this is complex. I suspect there's true ILD progression, but I certainly wouldn't measure the volume reduction and say that's the ILD progression. That's the point I'm trying to make.
Considering her lung function test, 6 minutes walk test, and HRCTs, considering all those things, do you think that sarcoid can have a respiratory muscle involvement?
Yes, I do. I think it's possible. And I think the other thing is that steroids can induce that even at quite low dose for some people.
Okay.
So I do think both things are possible.
But would that respond to steroids?
It might do, although if it's steroid driven, it won't. So
the fact that she's significantly improved on giving her methylprednisolone, if it was for muscle involvement.
Yes, you're right, because in connective tissue disease, in lupus, shrinking lung, you can get responses with immunosuppression, including steroid and second-line agents. So, I mean, what are the scenarios here? First of all, you might say methotrexate's not working in her. That's unusual, but it's allowed to happen. Your azathioprine dose was lowish. It was only 100 milligrams daily. And I don't know how much she weighs. Maybe she only weighs 50 kilograms. But you might more normally have given 150. I think you've got to conclude that one of two scenarios, either inflammatory activity isn't responding, but what is unusual is lack of sarcoid activity signal in the lungs on PET. Or she's really not taking the drugs in the background, and I wouldn't use fluctuations in lung volumes to say she must be taking the drugs. I'm more impressed by the fact that when you know you've given them, you suddenly have striking responses. Or we have to conclude that we should try anti-TNF, but we are trying it in a setting where PET is saying there's virtually no activity signal. So it's a tough call. I would do respiratory muscle function if you can, and actually try to find out if you've got a muscle function problem. Let me put it like this. If you see the KCO nearly doubling and going hand in hand with fallen volumes, if you don't do respiratory muscle tests at that point, you never ever will. And I just think you need that bit much more information. I'm not saying I know this is the answer and explains everything, but I think you've got to find out whether a respiratory muscle problem is really contributing in a major way. It would be much simpler if it wasn't, but I can't explain the KCO otherwise, going up from 70% to over 120%. Sorry, I've spoken far too long about this particular case.
Any other suggestion from anybody?
Very interesting discussion here. And I think I need to go back to the case, I think, Alpa, and discuss how to proceed here. If she's complying well,
then
she's progressing, but look for extra pulmonary for sure.
Okay. I think doing her bone density.
Smita, yeah, we'll have to move on, Smita.
Okay, fine.
I think we're running short here. You're muted, Asmita.
Vinod, are you there, or I will move to my case?
I've joined, ma'am.
Yeah.
I've asked my
Start.
PG to present.
Yeah, start presenting. We're running.
Yeah. Good evening, everyone. Am I audible, ma'am?
Yes. Please go ahead.
We are from I'm Dr. Mohammed Ayub from Ramchandra, Chennai. Here we present a case of 42 years old female from West Bengal who is a homemaker with a background history of rheumatoid arthritis, diagnosed in November 2024. Since then, the patient was on currently on MMF, HCQ, and leflunomide was started. Following which, since March 2025, patient was on home LTOT and nebulizations. Was initially admitted in the outside hospital for 4 times for similar complaints and was treated with antibiotics and nebulizations. She didn't have any recurrent oral ulcers, shortness of breath, Raynaud's, or no joint pains was present. Currently, a patient present with a history of shortness of breath for the past 2 years, with slight worsening, increase for the past 4 months, loss of appetite and weight of 10 kgs in the past 2 years, complaints of fever on and off for the past 4 months. There's no any family history of rheumatological illness in the past. On presentation, SpO2 was around 80% in room air, heart rate was 100, BP was 110/70. On examination, bilateral V's and cryptations was present. We did a CTD workup which showed rheumatoid factor of 819. Our ANA was negative. Anti-CCP was 202. Extended LA23 was done, which showed a positivity for RNP SM1 plus, MI2 beta 2 plus, and SP 103 plus. Creatine, RFT, LFT, everything was normal with IG of 300. So CD thorax was done, which showed right middle of bronchiectasis. Central lobe nodules was there. Hence, BAL was proceeded, which was inconclusive with a BAL smear, nocardia, fungal smear, nocardia, AFB culture, and gene expert was negative. 2D echo done, which showed normal chambers, no regional abnormality, EF62, and normal pulmonary artery pressures. Patient had a type 2 respiratory failure and requirement of NIV was there. Hence, PFT was not done for the patient. Currently, rheumatology opinion is obtained.
I think we'll see the CT scan.
Yes, ma'am. Yes, ma'am.
Bhavin sir. You muted?
No, I didn't start only. I was just thinking that we would do this case without the CT because he anyway described the findings.
No. I was like, yeah, we'll not. No. He's the new person. It's okay.
Yeah, very enthusiastic. So, okay, this if you look at the lung images, it's an airway disease. There's no interstitial lung disease, and it's all tubular bronchiectasis, peribronchial thickening, these branching centrilobular opacities and nodules. And it's more in the lower lobes, but it's there across board, little asymmetric. So you basically have an infectious bronchiolitis. The right middle lobe shows a little volume loss, and these are findings that have also been described with NTM as a superadded infection, but also, there's this entity called follicular bronchiolitis. I don't like to use the term because nobody, I think, really understands what it is on radiology. But, that's if you have a lot of bronchiolitis, that's a term sometimes people use. But more than that, I would just assume this is a superadded infection. And that's about it. I don't have expiratory images to see the extent of air trapping, but there is air trapping. There are small lymph nodes here and there, but nothing very significant and nothing else in the rest of the CT.
I'll go back to this.
So what are the questions, Asmita?
Yeah.
So we want to discuss the radiological patterns there. This, as Sir discussed about bronchiolitis and the significance of extended LA23 report and the impact of treatment approach. We have started pulse a patient with methylprednisolone of 250 mg for 3 days, following which Dexa 8 mg was given and was discharged with prednisolone 20 mg. Ma'am.
Oh, sure. Mithun, are you there? He just wants.
Yes.
Yeah. Please, can you?
And this patient, rheumatoid factor is positive. What is the anti-CCP? 2
Yes, sir.
Definitely rheumatoid arthritis. He is having underlying rheumatoid arthritis. This extended what we call ANA profile. The SP100 is actually autoimmune liver disease. His liver disease, liver function looks okay. Therefore, that may not be significant, but in future he can develop autoimmune hepatitis. That's it. That's the importance of SP100. MI2 is basically dermatomyositis. If he doesn't have any features of dermatomyositis, that is of no significance. UNRNP in a very low titer, not significant. When UNRNP is positive, it should be positive in very high titers. That is for MCTD. In MCTD, you can have rheumatoid factor anti-CCP positivity. Here, actually, which we are concerned is the UNRNP titer, which is a low titer, and I think it's not suggestive of MCTD. This is a patient with rheumatoid arthritis with a lung
Bronchitis.
problem, bronchitis.
Yeah. So I'll just share one more question which you people have put. 1 second. Yeah. Further management.
For the management.
Okay, if you consider there are two components, I feel. One is pulmonary component, which can explain breathlessness and the radiological finding underlying RA with showing bronchiolitis, and you have BAL showing no gene expert TB common over here. Fungus, probably we may have to look for again once more. And extra pulmonary cause must be there for fever and weight loss. So we should look for somewhere else pathology happening, and the lung is also associated with bronchiolitis following rheumatoid. She's on good amount of drug for rheumatoid arthritis. Despite of that, if the bronchiolitis is there, we are giving rise to a type 2 respiratory failure. So the fever cannot be explained, weight loss cannot be explained on that. I think we should look for something else somewhere in the body.
Okay, sir.
What is the CRP, percent CRP?
CRP was initially it was around 20, sir, on the start of treatment.
Okay. Not
Does
very.
Does this SP100 3+ change the management, Mithu?
No, sir. No. That usually we see. That's like anti-mitochondrial M2, no? AMA M2 also
Correct.
we usually see. Primary biliary cirrhosis. It's likely if patient doesn't have any liver features or hepatitis, it doesn't matter.
Sure.
The BAL AB culture, final culture was negative.
MGAT culture yet to be released, ma'am. It's been recently we done the case, so it take around a couple of weeks more for the reports.
Sure.
So that's not yet come negative.
No, ma'am, not yet.
How is this her arthritis? Well controlled?
Arthritis, no, sir. Still the pain is there for her. She complains of severe pains. Joint pains are there.
And the current DMARDs are methotrexate?
No, sir. MMF and steroids have been recommended by rheumatologists, sir.
Okay.
So they've been involved, and they initially suspected because patient had 2-3 episodes of recurrent infection in the last 6 months. They suggested definitely it could be infective source, TB or NTM. So
But
we did all these.
your cultures are all negative, right?
Yes, smears and cultures and fungal culture is yet to be released, sir. And microbiota culture also will following up.
So your rheumatologist doesn't want to consider rituximab or tofasibart?
Considered, sir, but patient has affordability issues. Even for this treatment, we were keeping her on free side, and we are trying to manage it.
I think anyway, before ruling out any infection, it would be difficult to start rituximab.
All cultures negative, Alpha.
Look, AP culture is
Yes,
yet
sir.
to come. 2 weeks.
Yes, AP culture yet to be released, sir.
Is awaited. Athol, you were saying something?
Yeah, I think so. I'm really quite puzzled by this case. Having seen a lot of rheumatoid arthritis, bronchiolitis, I don't understand if that's the basic problem, why she's in respiratory failure. Now, I think you can understand, we're not talking about follicular bronchiolitis here, that's the Sjögren's association. And one suspects you could in rheumatoid also have Sjögren's and get the occasional FB, but it doesn't look like this. And the bronchiolitides broadly, I don't believe the series which says that there's an equal prevalence of what we're seeing here, which is a sort of, in some ways, a pan-bronchiolitis overlap, and the more traditional mosaic attenuation without this signal in airways. I think the latter is much more common. But I am genuinely puzzled. You've got to come up with something extra that has sent her into respiratory failure. Just looking at the severity of the process and what its usual impact for that level of severity. Now, I find more attractive that she's getting into a lot of trouble with infection. And the moment you're saying that, then infection could be producing more respiratory compromise than you're seeing on a scan. Now that would make sense, but if that is so, then exaggerating immunosuppression might not be the best answer. And I'm just a bit bothered by viewing these lung problems as chronic as you see them on CT. And the level of impairment she's getting, just based on a strong sense of how sick people ought to be with the amount of disease on a scan when you've got bronchiolitis. So I would be really emphasizing infection as the key cofactor. I would be a bit worried about going full on to more heavy duty immunosuppression. You might be forced to, this might be an outlier, but okay, I've shared my slight unease about the case, and I think that's enough from me.
Okay.
You're
So,
muted, Sujit. I know you're saying something quite
I think
decisive.
AFB, I thought the cultures were all negative, but I'm now understanding, Vinod, AFB, NTM still awaited?
Yes, sir. MGT culture we had sent, sir. It usually takes 4 weeks for us to get the cultures.
Sure. So I think I would wait for that first.
Sujit, if this would have been NTM of tuberculosis,
Yeah.
BARD would be full of bacteria, acid-fast bacteria. So which is
Yeah.
not there means
No, I agree. Gene expert would have been positive. So all that is negative. So I'm assuming if it's all negative, does it? And her joint pains are what are troubling her as well. So whether we should go to more immunosuppression, but I'd leave that to the. What is bothering her more, the lung or the joints?
Can weight loss be explained by rheumatoid arthritis? Can fever will be explained by rheumatoid arthritis?
Low-grade fever can be seen in high-grade rheumatoid arthritis, but not like a low-grade evening rise of temperature can be seen. Otherwise, typical fever is usually very rare in rheumatoid arthritis.
How is she lung-wise, Vinod? She's moving around, ambulatory.
She's not very ambulatory, sir. She's oxygen dependent.
Okay.
And we are giving rehab exercises. And during hospitalization, is it because of steroids or she didn't have any fever spike during this? And her total counts were normal.
Right.
And the smears are negative. That's when rheumatology suggested pulsing. And she had better. So she improved from BiPAP to NIV requirement. Again, came back to BiPAP and was weaned off to oxygen and overnight BiPAP. But again, after 3-4 days of not using BiPAP after discharge, she landed up again with exacerbation. So the last question was like whether vaccination can be a key factor here. So with a lot of immunosuppressants, what would be the ideal time to vaccinate?
Here, actually, the vaccination probably will come later on. So at this stage, we have to solve the problem. Whether the BAL sample, if it is still there, we should still look for a PCP, PCR, CMV, PCR, where money is there, or galactamin level. And so, because sometimes you can have a PCP with normal HRCD not showing alveolitis and hypoxic so much. Okay, or even CMV infection also can have for low-grade type of fever or having for a prolonged period of time because of an immunosuppressant.
I think vaccination is not the most critical question at this point of time, Vinod. I'd rather get infection out of the way. So I think your working diagnosis currently is rheumatoid arthritis with bronchiolitis. Am I right?
Yes,
in chronic respiratory failure, rule out infection, right?
Yes,
Just look for a fundus examination by dilating pupil and see whether we can get something.
Sure, sir.
And hi there. Further, I'm just wondering what is the role of mycophenolate here? I don't see any role in giving mycophenolate. What do you think, Mithun? Is there any place of giving mycophenolate for her? Because I mean, in the lung, it's bronchiolitis with the infection, isn't it?
Yes, but for the arthritis, mycophenolate may not work.
Have you thought of
Sir.
So azithromycin is quite efficacious in panbronchiolitis. It's not an immunosuppressive drug. It will have broad antibacterial activity. I think there's got to be some bronchiolitis there because you wouldn't get bronchiectasis as part of a process occurring just because of more acute infection. So I don't question there will be a bronchiolytic process underneath, but I just think it's exaggerated by infection. And that's the worry about too much immunosuppression. Even you probably have to use it for systemic disease. That's a separate issue. So is erythromycin possible?
Sure, sir.
Yeah, I think the macrolide is a very good idea to add on, Govind.
Yes, sir. Yes, sir. Sure, sir.
I think we need to move, Asmita.
Thank you, Vinod, for presenting this case. We'll move on to the
Thank you.
third.
Thank you.
This is Mr. S. Bhavin, sir. We will take that case first. So he's 61 years old. He's a gate manager in railway, and he has many comorbidities. One of them was non-Hodgkin's lymphoma, diffuse large B-cell lymphoma, stage 4B, and he was treated for the same in 2018. He was on long-term follow-up. At the time of diagnosis, he got intracranial dose of methotrexate also for CNS prophylaxis, and he received R-CHOP regimen 3 dosages. And 2018 onwards, he's on long-term follow-up from my medical oncology side. He was referred to me because he has cough with yellow expectoration and intermittent breathing difficulty. What he told was he was perfectly all right. He had some road traffic accident, and because of that, he developed chest pain. He was due for CT scan somewhere in June or July, but he came early, and CT scan was repeated earlier than the planned visit. That is how it happened. So the cough and breathing difficulty was just episodic after the accident. It has this was whatever we are going to see on the CT scan is an incidental finding. What I'm trying to make out is that his vitals were stable, and this is his blood investigation, which we checked because we wanted to rule out the relapse of lymphoma, but that is all static. LDH is static. His blood reports are status quo. There was nothing required from oncology side, so they referred to us for the evaluation of the thing. These are his spirometry, which was done around 2 weeks apart. And now I would like Bhavin sir to show the CT scan images.
Okay, so what we have are the 2018 images are on the right side here. He had a full-blown lymphoma, all of which has gone. The lungs at that time were normal, so there's nothing else. What we have now is another patient with an inflammatory bronchiolitis. You see these ill-defined branching centrilobular opacities. You know, if you were to do a little bit of a MIP here of 3 mm, you'd actually see them a shade better. Upper lobe predominant, the lower lobes are less involved, and that's pretty much it. There's no bronchiectasis, there's no peribronchial thickening, there's nothing else that this patient has. Patient's not a smoker, right, Asmita?
No.
Okay, so that's it. It's an indeterminate inflammatory bronchiolitis. That's it.
So there was a doubt that that I could see tree in bud pattern, but I was thinking, is it miliary? And that was the doubt
No,
that
no.
no,
So
you don't feel now, yeah.
So these MIPs are very useful, you know, when you're looking at that. So you can actually see the branching. Look at this
Yeah,
one, for example.
I felt
You
like
see
that
Yeah,
I felt it
yeah,
was tree in bud
yeah,
kind
yeah.
of
So
thing, and
miliary, miliary would be just discrete 2 to 3 millimeter
yes,
nodules, and there wouldn't be any zonal predominance. You'd have equal
it
involvement
should be.
in all the
Yeah.
segments. Yeah.
These
So
aren't random either, are they, Bhavin? They're not
They
random.
are no, so they are tree in, I mean, there is a tree in bud, predominantly upper lobes, and that's it. Yeah. So
Okay.
yeah. So then anyway, we discussed with our radiologist, and we decided to go ahead with a biopsy in concordance with the oncologist side. And the biopsy images I took from right upper lobe because my radiologist also felt that there is upper lobe predominance. Even though the upper lobe biopsies are difficult, we could get some granulomas. Ritu madam, your comments.
So this is an endobronchial biopsy where we can see the epithelium on one side and well-defined, discrete, non-necrotizing granuloma can be appreciated on this power itself. And if we take it on the higher power, which is the next slide, you can see this non-necrotizing epithelioid granuloma which is there. One thing which appears to me is I think there is a Schaumann body here, which I'd like to get a deeper cut, because this where the arrow is going, if you just extrapolate the arrow down, yeah, this cell here with the little bluishness, I have a feeling
This
will turn
one.
out to be, yes,
Yeah.
will turn out to be on a deeper, might just turn out to be a calcified lamellated Schaumann body. So, and the third slide which we have is of the pyridic acid shift stain, where again the granulomas are seen. So for me, this patient, I would like to get some deepers and do a von Kosa and rule out a sarcoid-like granuloma.
Okay, that's great.
Yeah.
Thank you. So
Yeah.
my question to pathologists were, given the granulomatous histopathology, the negative stains on cultures, can this be confidently labeled as sarcoidosis or TB, or is there any other differential? And could this granulomatous pattern be paraneoplastic response to lymphoma? Because sometimes we see sarcomatoid reactions in lymphoma, right? So those are the
Yeah.
two questions too.
But this is not sarcoid. I mean, there's
No,
nothing in the
yeah.
The
radiology
culture is
that
negative, Asmita?
Cultures are till now expert, and everything has come negative. MTB panel will be awaited, but I don't expect it to come positive as such.
I mean, this
Yeah.
is where we're looking at correlation. I mean, if I tell Ritu that this is not sarcoid, then she'll have to interpret the granuloma from the perspective of
Yeah.
the fact that it's an inflammatory infectious bronchiolitis. I mean,
Correct.
so
Yeah.
I don't think we should go down the path of sarcoid at all. And
Okay.
sarcoid-like reactions post-chemotherapy occur with a very few select drugs. It's something we've been learning now with the immunotherapy drugs, with some of the targeted drugs, etc. Your usual regular chemotherapy rarely, if ever, produces sarcoid-like reaction, and those are acute, subacute. We know because we're picking them up on PET CTs quite commonly now, and so we've understood what those look like. This is not even that. And so this is just an inflammatory infectious bronchiolitis, and that's about it. So
But this has come positive in endobronchial biopsy, right, Dr. Asmita?
This is transbronchial lung biopsy.
Acha, not endobronchial.
No. Endobronchial, there was nothing. This is lung biopsy which we took.
Yeah, I think it's better to bring these cases back, Asmita, with the cultures come in and you have your full micro workup.
Yeah.
Because then it makes more sense to discuss that. This is
But he doesn't have any features of infection, and how can I explain granulomas? Like if bronchiolitis is not
No, but then why
granulomatous.
would you send the cultures? Why would you send the cultures if
No, I wanted my first differential were between TB or sarcoid. That is why I sent the investigation. His Manto came negative. His other markers are negative. Now I have not started him anything. I'm going to keep him under observation because I don't know what it is. So
wait for
and
the
he's
culture.
asymptomatic. What to treat and why to treat. So
That's all
while
we
sir,
we
when
can't have a
today
working diagnosis here. I mean, we'll have to still wait.
ACE level was negative, ma'am. It
So
was around
my
86.
question is, if asymptomatic, then why work up the patient with bronchoscopy and biopsy?
Yes, because
just trying
oncologist
to.
was concerned. Oncologists were concerned that are they missing or relapse, or is it some infection which they have missed? So the reason was to rule out
Asymptomatic
tuberculosis.
infections 8 years
Yeah.
after a treated lymphoma. I mean, no,
Because
we
you're going to say something, Athol?
I'm going to say I think there's too much certainty going on here.
It's certainty based on uncertainty. So that's what.
I've seen the occasional case of sarcoid in my career, and I would say that pontificating this is definitely not sarcoid is a trap I've fallen into from time to time. So I think you're absolutely right to follow Bhavan's first instincts and believe it to be infection. But when you don't find infection, you're going to have to be, as Sherlock Holmes said, when you've excluded the impossible, what remains, however unlikely, must be the case.
Yep.
Now, we know there's an association between lymphoma and sarcoid. We know that it can be unusual looking sarcoid. We know it can come before lymphoma, it can come after lymphoma, and when it comes after lymphoma, it will often come quite a long time after lymphoma. It's the distinction between benign and malignant lymphogranulomatosis. And so I quite understand that this is not a typical sarcoid CT phenotype. but I think about 20% of sarcoid are not atypical CT phenotype. I'm not sure I'd go using the term sarcoid reaction because all sarcoidosis is actually a reaction. It's almost certainly failing to deal with an antigen in a person with the wrong makeup who runs into the wrong antigen, and it can't be cleared, and it promotes instead secondary responses that amount to sarcoidosis. I very, very much doubt that it's a manifestation of lymphoma. And I can understand an oncologist who doesn't feel as confident about that might require that. But I would say stick to coming back to this case when you've rigorously excluded infection, and don't reach any conclusions till you have. I suspect Bhavan will turn out to be right, by the way, but if you don't find infection, it would give me great pleasure to find that maybe he's wrong.
But he doesn't need treatment, right? We just have to observe. And how frequently I should repeat a CT scan if I want to follow up?
I think that you found this as an incidental finding. I think you do need to sort out, if you can, what it is. But there's no grounds for doing anything urgent and over the top. You can wait for full cultures. You can give it a bit of time. You can find out if this regresses spontaneously, which would, I think, mean you don't have to worry about what you call it. If it is triggered by infection you can't find, then, and it goes away, then you don't really have a problem. So I wouldn't impose too much on this patient.
Okay.
I would say just be gentle.
Okay.
Come back with a scan because it is quite a profuse finding on the scan, and
Sure.
you're not sure what it is. But if it has been triggered by a transient infection, hopefully it will go away.
6 weeks to 3 months, yeah.
And I agree. The only thing is you shouldn't see a sort of quasi-tree and button sarcoid, and I understand that it's unusual. Occasionally we have, and I've never liked it, and I've always suspected that something more than sarcoid was going on, and there was an infection.
I'll follow up the cultures, yeah.
But don't rule it out because of this association between lymphoma and sarcoid. That's really all I'm saying.
Sure. We'll move on to the next case, which is equally interesting. And so this was a 47-year-old lady. She was treated as asthma. She has uncontrolled asthma and she is on and off steroids. Presented to us with cough, yellowish sputum production, and GERD symptoms. Mainly on lying down, her symptoms worsens. There was no fever, chest pain, hemoptysis, or loss of weight or loss of appetite. Vitals were stable. This is for you, Mithun. Anything significant you find?
Centromere antibodies mildly 1+ positive.
She doesn't have symptoms. Yeah, clinically no CTD stigmata present. ESR of 28 and CRP of 12. ANA was 1+, fine speckled.
If you get a centromere antibody positive in ANA immunofluorescence also, you will find centromere pattern. That is a classical for centromere antibody. In this case, this is not significant.
So both are not concordant. So you feel this is not significant. Counts were 15,000. Now this is something which I don't know whether it is significant or not, but her eosinophil counts were 49%. And this was on 1st of April when she came to me first time. And this is her spirometry, which I did on second visit after the ANA and everything was available. Her spirometry was well preserved. She walked 360 meters and 99 to 99, no desaturation at all. Echo I didn't do yet. CT image will be, Bhavin sir will be showing. Yeah.
Okay, so I was off Zoom for the last 2-3 minutes. Something happened. So we are looking at your fourth case, right? 47.
Yes. Yeah, that girl, lady.
1 second. So just let me know if this is the same patient that we're looking at, right? This is
yes.
Okay. So I didn't catch the history because I just got back in.
So asthma history, Blood reports are suggestive of eosinophil count of 49% in CBC, but other parameters are negative. And history, there is one significant history which I forgot. Her neighbor's house, which is around 200 meters away, has got plenty of lovebirds. That was another history which she gave to us. But overall treated for asthma on and off steroids for many years now, oral steroids.
Okay,
She
so
has an absolute eosinophil count of 7,000
Yeah,
approximately from
yeah.
2000.
When she came to me first time, when the CT scan was taken, yeah.
so some prominent axillary lymph nodes here on the right side. Nothing in the mediastinum and hilar region, so I'll get that out of the way. When you look at the lungs, again, very subtle centrilobular opacities in the upper lobes. And as we come more inferiorly, very, very subtle, but they're all kind of more airway based. Again, there's a history of asthma. Little bit of peribronchial thickening if you want to find something. And that's really it. There's no interstitial lung disease. There's nothing else of significance. A little bit of a subtle subpleural ground glass. All these, in fact, are findings that you can get in asthmatics. The one on the right here is the expiratory scan that's showing some patchy air trapping in the lower lobes. I mean, this is not syncing accurately, but if I just put these together, you can see how there are a few lobular areas of air trapping. Are they significant? Depends upon the situation and the extent of disease, because in many Indian urban patients, you do find this amount of patchy air trapping often normally. So that's it. That's where we are. There's nothing, a little bit of inflammatory bronchiolitis, again, no interstitial lung disease, and some areas of patchy air trapping.
Okay. Yeah, if you, yeah. So the questions were, so are the CT findings are anything you found in favor of eosinophilic pneumonia, HP or small airway disease, which you will grade first, sir, and whether Bal will help me, or should I send Anka for this patient? I think that's it, my questions.
I would just think this is airway disease if you want to give it a name.
Asthma, yeah.
That's
Okay.
it.
Okay.
You could treat for tropical eosinophilia, I guess, considering we're in India
Yes,
with
sir.
that eosinophil count.
Yeah.
Well, Prahlad?
I think, I agree with you sometime tropical eosinophilia, lung shadows would have been much more, predominantly peripheral eosinophilia,
Sure.
with some small airway obstruction, but pulmonary function doesn't show. But she said a lot of reflux symptoms are there. So we must do an upper GI to find out we should not missing an eosinophilic gastritis or eosinophilic disease inside, which is not uncommon, so that is, then we can document there are eosinophilia and somewhere else also.
She has uncontrolled asthma also, and most of the times we might miss this EGPA and all kind of, right, sir? So.
But nothing on the EGPA workup was positive, right?
I didn't send, sir. I think I'm waiting for repeating the CBC once more. This is just came, so I would further see whether eosinophil comes down and then start working upon that, and that's what the plan is.
Sometime we should repeat a CBC once we get a eosinophilia high, and we don't get a really.
Yeah, next time it may not come, so I don't want to text her unnecessarily because I did other investigation.
Right.
Yeah. Anybody else? Muliman sir, I didn't hear you today at all. Anyway.
No, I've been missing parts of it. I've been on the road. But I think the first thing I would think of with this is tropical pulmonary eosinophilia.
Yes,
so
sir.
I think that's worth ruling out before we do anything else.
Yeah, so we have got 2 cases of Rajan sir, and we will go first with the pathologies thing.
Yeah. So this gentleman is young, 35, staying in Bihar, northeastern state of India, works with CISF, never smoker, married with a child, and was working near the coalfields in Dhanbad for almost 1.5 years. He has been struggling because he works with CISF. He's been struggling during training in 2013-14, especially while running. And about 1 year now, he struggles to breathe even on 1 flight of stairs and a fast walk. He dropped saturations even on a gentle walk, occasional cough, no family history of lung disease or autoimmune disease. And his treatment history is that he's been on oral corticosteroids for 9 months. Currently, was seen in Pune. I don't know if Lakshmi is on the call, but he's the pulmonologist who's been treating him in Pune and who sent him to me on 50 milligrams of prednisolone, nintedanib 150 twice a day for 3 weeks, and an MMF 500 BID. His autoimmune workup, as you can see here, is negative. In the myositis blot, PL12 was positive, 38 titer. If you have the photograph of the blot, Asmita, yeah, this was how the blot looked, Mithun. And so that was that. Next slide. And these are his lung functions in the last 1 year since he's been, he was first evaluated with lung function when steroids were started in July 24. And clearly lung functions have dropped. DLCO has dropped significantly, and he's been desaturating right since July 24. And so, next slide. Yeah, the CTs and then a cryobiopsy done by Lakshmi, and then I'll tell you the questions I have.
Okay, so again, when we're looking at just 1 second, sorry. So if you just look at the soft tissue windows, there's one calcified subcarinal node and there's nothing else of significance. So I'll get it out of the way. We have reticular opacities. There are in the upper lobes, there's some subpleural involvement, but you do see a little bit of exuberant cystic change and honeycombing in the anterior segments of the upper lobes. Then let's start from below. You again see a lot of these reticular opacities, subpleural involvement, very sharp margins. And whenever you see sharp margins like these, one of those used to be is called the straight edge sign, but you don't have to have it just there. Any sharp margin should make us a little concerned about possible connective tissue disease. And then in the middle and lower lobes, there's a combination of ground glass and reticular opacities. There is an axial distribution along with the subpleural process. So this is where we are. It's a fibrosing ILD. It is non-UIP, non-IPF in that sense, but there are sharp margins which suggest that we do need to look for connective tissue disease. No significant air trapping, so that's not really of concern. And if you just look at the coronal images, just gives you a sense of the pattern of disease. And so I would just say this is indeterminate, but two signs that suggest connective tissue disease is this anterior upper lobe exuberant honeycombing and cystic change, and the sharp margins and sharp edges in the lower lobes.
Sure.
And so Lakshmi in Pune did a cryobiopsy because everything wasn't fitting in, I guess, for him either. And yeah, he did a BAL first. Yeah, can you go to the last slide, Asmita? That was the differential count on the BAL. And it's a lot of polymorphs there. And this was, yeah, Ritu?
Yeah, hi. So very nice cryobiopsy which has been done. And we can see that there is a good amount of fibrosis with architectural distortion on the left side of the image. And on the right image, we can see that there is microscopic honeycombing, which are lined by bronchular epithelial cells, which are lining them. Then if you see the next slide, the next slide also is showing, in addition to the fibrosis and the microcystic honeycombing, now you can see on the left image, if I can zoom into that, you can see that there is perivascular fibrosis which is coming up. There are lymphoid follicles which are formed, and so that's the second compartment which is involved, the vascular compartment which you can see, and the lymphoid follicles which can also be seen. On the right side, the upper image is showing mixed interstitial inflammation comprising of lymphocytes and macrophages and fibrosis. And the lower image I kind of put there to show you that in addition to the peribronchial metaplasia and the thickening, now there is some amount of neoangiogenesis also which is occurring. So a lot of changes which we can see on just these few images. Next slide, please. This is the image where we can see that that pale area, which is the fibroblastic focus, and which is lined by the bronchular metaplastic epithelium. So this is the advancing edge of fibrosis, which can be appreciated in this. And of course, there is the surrounded by the active fibrosis and by the cystic change. Next slide, please. Okay, so here on the right side image, there is intervening unremarkable lung parenchyma has been sent. But if you see the center part, you can appreciate that there is a lymphoid follicle which is there, which is in the area of the bronchiole. So whether it's an obliterative bronchiolitis, follicular bronchiolitis, I cannot comment on. But that's on the right hand, but the rest of the parenchyma is normal. And on the left side, we can see
dark purple area, Ritu,
yes,
is the lymphoid follicle.
yes, and it's in the area of the bronchiole actually, because the vessels are here, just lower to it on the left hand side. So that could be a follicular bronchiolitis. And on the left side image, there is again the cystic change lined by the bronchular epithelium, and there is lymphoid follicles formation which can be seen. So we go to the next slide. I think last slide maybe. No, there are two more slides. Yes, next slide, please. No, there. The one before this. Is there anyone before this? Yes. So on this area of the lung parenchyma, we can see two changes. One is there is intraalveolar hemorrhage, and the other one is that there are some alveolar spaces on the right side. You can see where there is some proteinaceous fluid in the dilated alveolar spaces. So that can be the alveolar proteinosis. You can see it in the lower power also as well as in the higher power. So there is some amount of alveolar proteinosis and some alveolar intraalveolar hemorrhage which is occurring. And so vascular compartment is involved. And you see the last slide here. It is showing hypertrophy of the vascular smooth muscle cells. So this is over medium-sized arteriole. And there is vascular smooth muscle hypertrophy, which is there. So, so for me, this would be because UIP definitely like picture, because I'm seeing temporal heterogeneity, I'm seeing spatial heterogeneity, I'm seeing fibroblastic foci, I'm seeing architectural distortion, and intervening normal areas. But considering the lymphoid follicles which are present, I like to keep whether I'm dealing with a CTD ILD first and then an ITS.
Thanks, Ritu. Prahlad Murli Athol. He's 35 years old, and my questions are really, he's on MMF 500 BID, he's on 50 mg prednisolone. I've obviously cut down that dose to 30 right now, but would you look at rituximab for him, or would you, because committing him to an antifibrotic based on those scans, Bhavin, can you pull up those scans once more so that Prahlad and Athol can comment on those? Prahlad, what do you feel here?
Yeah. See, if you consider that BAL, which is neutrophilic.
Yes.
One, okay. Second important thing is that I remember that the whole histopathology is not cellular. It's a
there's so much happening on it. Yeah, there's so much happening. Yeah,
it doesn't look like in idiopathic pulmonary fibrosis or like that. So it is some sort of an inflammatory lung. Okay, with I don't know how much neutrophilic versus lymphocytic type of. I know that is something questionable. We have to discuss that. But this is definitely.
So though Ritu says UIP, like this is not IPF. Sure. I agree with that. Yeah.
The cellular pattern is there, and
right.
This young age distribution of the pattern, Bhavin has showed very classically that it is not very fitting into a certain sort of idiopathic. It is most likely be collagen. We are missing, probably he will manifest later on CTD-ILD if
Sure.
the arterial pattern is
So
not
would this be a myositis, you think, with that PL12 positive?
possible. I mean, I'm not expert in that.
That's
but
why I was thinking of, I don't know what Mithun feels or Sanjeev, if they have a thought here. Yeah, Mithun?
So the antibody is actually strongly positive, moderate to strong positive, 2+ positive. We need to give significance to that. And it is not multiple antibodies in low titer positive. It is that antibody in a 2+ positive is significant. And what about, does he has any mechanics and proximal muscle weakness?
No.
High CPK?
No, CPK normal. CPK normal. I put that up. Yeah.
Even the alveolar proteinous material which is seen also indicates that there's active type 2 pneumocytes probably inside. So this is some sort of an
Athol?
Well, I would pull out the stops in this case. I'm not disagreeing remotely about the scan. It doesn't obviously look like UIP, but the fact is the truth data are the biopsy findings here. And the biopsy findings, good cryobiopsy, very compelling for UIP. And unfortunately, even in what we call IPF, 10% of patients have weird CT appearances, most often with a family history, it's true. But certainly I've seen patients like this that did not have connective tissue disease, and we had to call them weird IPF. I don't believe that here. Hearing about the CT findings supporting CTD-ILD, hearing MIFIN, knowing about the SONG data, that in UIP CTD, lymphoid follicle enlargement is a signature feature. So putting all that together, CTD-ILD, sure, but this is evolution on its way to UIP, and fairly heavily on its way. Now, the DLCO is disastrous. It's 15%.
16%. Yeah.
It's difficult to be alive if you're below 10%. So this patient has traveled 90% of the way from the starting point to death at this point. So any intervention, I think, has to cover UIP progression, has to include an antifibrotic.
Sure.
I think you're quite right to combine mycophenolate and rituximab. The EVER-ILD study wasn't about UIP, but I think this is a matter of the crime is to miss an opportunity. Could you reverse an inflammatory component in this? And if you fail to do that with a DLCO of 15% and a UIP pattern, don't think he's going to live for very long. Whether transplant's in the offing, if so, it's an urgent referral.
Sure.
What age did you say?
35.
Right. So
And
I think
symptoms started when he was much younger, wasn't it?
He started finding reduced effort tolerance about 11 years ago in training. He was in army training that time.
Yeah, so Professor Athol, I just wanted to point out that, it's been going on a long time. So sorry to interrupt you.
Yeah, it has, but he's got 95% of the way from a normal DLCO to death. So I think that once you see there's a UIP pattern underneath, whatever it's evolved from, Murali, we don't know whether this is evolution from preceding NSIP. I think there is a subset of patients we see it in HP that they develop a UIP pattern. In IPF with a UIP pattern, we know there are airway insults sometimes decades beforehand. I think the existing ILD is another insult that could lead to triggering UIP as a process. And I'm sure, Murali, that's not been there for a very long time. Suspect the UIP that we're now seeing may be a much more recent development.
But I thought the neoangiogenesis and vascular smooth muscle cells that Ritu mentioned, does that suggest anything?
Not necessarily, and I've pressured Andrew Nicholson on that, who makes the point in a very aggressive interstitial lung disease, you will sometimes get difficult to understand vascular signal. The proteotic element, you see a bit of proteinosis often in NSIP. We had a CT series in non-smokers with NSIP where the majority had an element of crazy craving, but it was histologically proven NSIP. So I don't think we should be using the word alveolar proteinosis here. I don't think we should be using the word vasculitis. Now, it may be that as part of the CTD, as a multi-compartment disorder, you will pick up a bit of vascular signal. But I wouldn't really view that as part of the primary process that is going to be the determinant of early mortality in his case.
Thank you.
I don't see an intervention that you should direct against the vessels.
So I think connective tissue disease, ILD, I wouldn't say rapidly progressive, but progressive for sure. And antifibrotics to be used in rituximab. Sanjeev, would you also agree before we go to the last case? You're muted.
Yeah, okay. So, basically, I think Dr. Mithun is there, and this PL12, I think that's the one that is positive. So, from a clinician, and as I earlier mentioned to you in this week, that there is something called as old-fashioned thinking and something that is modern thinking. Now, the old-fashioned thinking would be to treat the patient and not the reports. So I don't think that PL17 has any significance because you do not have clinical symptoms of myositis or anything of that sort. And all that we should do is to immunomodulator. I don't like the word immunosuppression. Steroids only have a very short period in which they help to reduce inflammation, but there has to be a long-term medication. So you should do either a T cell modulation with mycophenolate mofetil, or you should do a B cell depletion starting with rituximab. And you can even combine the two of them so that you can get all your inflammatory activity in the lung parenchyma under control, whether it is of a rheumatoid or whether it is of PL17 or it is of a MDF5, it doesn't matter whatsoever. Priority is to get the inflammation down and then follow up with the antifibrotic drug.
Antifibrotic, I'll start off. He doesn't have much time, as Athol said, and you're usually faster than me on antifibrotic, Sanjeev. So I'm going to start that. Okay.
I'm just wondering if there's any element of pulmonary vascular, I mean, like group 1 pulmonary hypertension going on. Is there any possibility, like because of this, vascular involvement and all? Is she having any pulmonary hypertension at all?
I don't recollect that, but I don't think anything significant, Amila. If at all, probably there were mildly elevated pulmonary artery pressures, which I would ascribe to the lung disease. Nothing disproportionate.
Just a little to add, a friend of mine, a rheumatologist from Australia, is listening in and suggests that PL12 is can be associated with an amyopathic form of ILD.
Okay.
Either way, you would immunomodulate, right, Murli?
Absolutely.
So I think
Completely agree. Completely agree. I think
I agree.
to answer your question, I would push up the MMF straight away.
So the last case, Asmita,
Yep.
you were saying something, Athol, as the last case comes up?
The amyopathic cases have the worst lung disease, actually.
Yeah.
So one small
the last case which came from Sanjeev to me, and we've been managing this patient. And we squeezed him in today, and that's why Bhavin is being stretched. Sorry about that, Bhavin. 66-year-old male, Bhopal resident, he designs dams, never smoker. He was very well till August 2024 when he underwent a laparoscopic hernia surgery, then started getting muscle pains in the upper limbs. In September 2024, not very specific pains. And since October, started getting breathless, after which chest x-rays were repeated along with PFTs. Because the chest x-ray showed up an ILD, there was CCP antibody positivity. The rest of the autoimmune workup was negative. CRP was high. He was started on methotrexate, mycophenolate, steroids, and nintedanib. So quite heavy-duty stuff. And he has lost 19 kilos in the last few months. PET CT done in Bhopal, negative for malignancy, no family history significant. And he's received oral steroids for the last 4.5 months, which is why Sanjeev said that's not the route to go. Currently on 5 mg prednisolone, nintedanib 150 morning, 100 at night. That's the best he can tolerate. MMF 500 BID and methotrexate 15 mg a week. So these were the autoimmune myositis blots were negative. And in Mumbai, 2 days ago, his RNA polymerase 3 was positive at 36.22, normal titer, less than 20. Next slide. When he had the hernia surgery done, this was his X-ray, and it was reported normal. he was asymptomatic. August 24. In December, when he started getting breathless, this was his X-ray. Next slide. And Sanjeev repeated the autoimmune serology in Mumbai, and this is what we had. We again had a CCP very highly positive, Mithun, 451 with a normal below 17. And the RNA polymerase didn't turn out positive there. It only came positive here in the Mumbai lab that we did it. Normal titer less than 20. And Bhavin, could you show us the scans?
All right, so I'm just putting everything together right now.
Yeah.
So the PET CT is of March 6th, and then 6 weeks later we have the new CT. If you look at the CT and the PET, you've got a full-blown UIP-like pattern, reticular opacities, subpleural involvement, lots of traction bronchiectasis, and it's all peripheral disease. There's no central axial disease at all. If you look at the PET, it's a lot of uptake in the lungs, which tells you that there's an active, significantly active inflammatory component in this patient. But then, strikingly, 6 weeks later, if you look at this scan, there is progression, and the progression is of fibrosis. You look at the traction bronchiectasis here, right, in the superior segment. I'm just aligning this image perfectly, just to give a sense. Look at this traction bronchiectasis here and see the extent of disease progression. And if you go, in every segment, there is progression. Now, one way to think of is there a superadded infection? But the superadded infection would not be only in the areas of disease. You would see them in the other non-involved segments as well. So this is all disease progression, and it's progression of fibrosis in a period of 6 weeks. And I did have a look at the films that were done in December, and there's been even between December and March there was significant progression. So this is rapidly progressive fibrosing ILD with in this case I would just call it a fibrotic NSIP pattern, but it's basically CTD ILD rapidly progressive. So
yeah. So quickly, we admitted him yesterday and gave him rituximab. Sanjeev and I decided this man was this is his lung function, by the way, September 24 down to, but of course, different labs, different prediction values. That was Bhopal, this was Mumbai, DLCO 56. He's quite breathless on walking, though he doesn't desaturate more than what you can see. Next slide. And so after Sanjeev and I had a discussion yesterday, we stopped all this, the MMF, HCQS, MTX. We plan to taper and omit steroids. Nintedanib, we have continued. Rituximab was given yesterday. So now Sanjeev and I have been discussing whether, I was thinking of bone marrow transplant, but I have no experience. So I need to ask Sanjeev and Mithun about that. And Sanjeev's been exploring CAR T cell treatment. Prahlad Athol Murli. Mithun?
Rituximab may take some time to act. No?
Yes.
Usually it's 4 weeks. When you taper everything,
yes,
suddenly that may not be. I think we can continue steroids for some more time, then taper. Otherwise, there may be a period where nothing is there. Then patient can worsen. Usually 4 weeks for the rituximab to have a maximum effect.
We have given some data before the rituximab dose.
You have completely stopped steroids?
No, we have made it 2.5 milligrams a day. Very small dose. And I can keep 5 mg going. Sanjeev, he's the primary physician for the patient. Does a bone marrow, I was thinking, Sanjeev, bone marrow here. Bone marrow transplant, Mithun, are these candidates or?
No, I have no idea. Bone marrow transplant usually stem cell transplant.
Stem cell, yeah.
No, sir, I have no idea on the. in this
And
case.
would you label this as a scleroderma ILD based on the RNA polymerase?
And I think only one value has the positivity. No, second you said it is negative.
No. RNA was positive yesterday in Mumbai.
RNA polymerase 3. Anti-CCP also positive.
Strongly positive.
RNA polymerase anti-CCP is for RA and RNA polymerase 3 is for scleroderma, and sometimes it can be associated with malignancy also. But whether patient doesn't have any features of scleroderma also.
No, I don't think so. Right, Sanjeev?
So, am I audible clearly?
Yeah, please.
Yeah. So here I just have a few points to make. Now, number one is that we have to take clinical decisions. So here's a patient whose wrists, whose fingers, whose shoulders, whose knees were absolutely normal whilst he was on steroids. There was no restriction. And the longest disease symptom duration was about 8 months. So in 8 months, you should have had something if that anti-CCP meant rheumatoid in this particular patient. So for this, in the clinical context, the anti-CCP is false positive. Now, scleroderma can manifest in multiple ways. We are still in the learning process of what the topoisomerase 3 antibody means, what the RNA polymerase antibody means, what the PMSCL antibody means. So all that is a matter of just discussion, which can go endlessly. Here you are facing an extremely aggressive lung disease with inflammation followed by fibrosis. We have to just remember that little point that fibrosis doesn't start on its own. It first is inflamed and rapidly the fibroblasts get stimulated, and then you have got multiple layers of fibrosis in the alveolar, around the alveolar cells. So here you have to be very aggressive. Now, for what Mithun mentioned is that, we are all standard of care, steroid all these years. But across the globe, there has been an increasing movement, I would say, a slogan which has been coined saying prednisolone is a poison or prednisolone is a problem. And I have now with me about 38 years of experience, and I have been treating my patients without steroids at all, including patients of lupus. Here is this gentleman who has already received a lot of corticosteroids. He is met us on corticosteroids, and you saw within 6 weeks the CT scan getting worse. So obviously he's a steroid non-responder, or the disease is rather too aggressive for the doses that he has been giving. We could step up the dose, but what will that happen? Short-term benefit. So we have to look at different mechanisms of immunomodulation, and B cell depletion takes place, is just a fundamental issue. So it's just taking away 5% of the B cells in peripheral circulation. So it works for a short term. It starts working pretty rapidly, and Sujit and myself have had that experience in our patients. We have given rituximab on day 4, day 5, patients start getting better, and then they continue to remaining well till the disease relapse in 6 months or 8 months, depending on the aggression of the disease. We as immunologists have been following aggressively the neoplastic surgeons and what do you call them as medical oncologists, and we have been basically following them. So what we have done is now wherever our patients are not responding to rituximab, we go for a deeper B cell depletion with another drug known as obituzumab, which is available in our country. We have in a related disease known as lupus nephritis success all by data in lupus nephritis, particularly in patients who don't respond to rituximab. So that's all over the place. And CAR T cell has already come into our autoimmune space with what is called as resetting the B cell mechanism, resetting the immunology. And you get a completely drug-free remission in patients of lupus, in patients of scleroderma, in patients of myositis, but the data is only less than a year old across everything. So I would say that here is a patient who has given us an opportunity to see whether the new drugs, which is primarily B cell depletion, and in these patients, the B cell works like a macrophage, like a antigen presenting cell. The B cell also liberates the cytokines. B cell does plenty of things, and if you can deplete them, you can downgrade the entire inflammation process and thereby hope that the fibrosis will also become less. So I think that's the line of action we are thinking. We are no more in favor of steroids. and we go for just B cell depletion, and we will report back to you what the outcome is. I can only mention that on day 1 after receiving rituximab, patient called me and said that, doctor, I'm much better. In fact, I have their email with me, and I'm leaving for Bhopal. I'll take my second dose in Bhopal, which was absolutely fine, and he's going to come back only after 4 months.
Yeah,
So
but
this is
that
the best
Sanjeev,
that we can do.
that Sanjeev could also be the dexamethasone he received before the.
It is the dexamethasone it has received,
Yeah.
because we have to give a dexamethasone to prevent that.
Yeah.
So,
I thought, what would the London rheumatologist do for such a patient?
Well, I'll tell you exactly what we'd be doing. First of all, I agree about steroid in this case. You've established definitively it's not working. I think it can be life-saving in certain situations, but I'm co-driving internationally an effort to declare war on steroids and sarcoid using exactly the logic we've just heard. In this case, you need fast action. And I have to say, in spite of what you say about rituximab, my experience with use of rituximab is that you don't get such quick responses in lung disease. Now, this may be different. Maybe we should keep an open mind on that. But if you're looking at this situation, the reason it's not UIP is it just doesn't look right on serial scan. UIP might be more progressive on average, but it doesn't march like this, does it, Bhavin? It's just not a UIP serial profile.
Right.
So I think it's really difficult in SIP. And I would be going through the list of things that might act quickly, because you're losing ground with every step. Now, I'm sure there's a reason you wouldn't give tocilizumab. I mean, this is not ATA positivity. You don't have skin thickening. But if this was scleroderma, this very rapid progression would be in keeping with that subset of patients. So we would be talking about, I imagine, with rheumatological wisdom in the conversation, we probably wouldn't use tocilizumab, but we consider it. I'd consider tacrolimus because that is an immunosuppressive drug or an immunomodulatory drug you prefer, which seems to act a lot more quickly than most of the others. And the Japanese experience and difficulty in SIP probably should be listened to. I would want to consider abatacept because some of the abatacept, it's all retrospective, but large series, quite impressive, with aggressive fibrosing ILD, mostly in rheumatoid, has been really quite impressive. But you won't have that set to hand, I don't suppose. And I must admit, there are no prospective trials, so this could turn out to be a blind alley. And then I think I would not be arguing with what you say. But the main priority is to get aboard something that acts as quickly as possible, because this is marching disastrously month by month.
I think the high CRP made you think of tocilizumab. I completely forgot about that drug because that's actually the setting. Sanjeev, would you consider it later, or if the CRP is
No. You see, we don't treat CRPs, and the tocilizumab, even one infusion will bring out the CRP immediately. So tocilizumab actually works against CRP rather than anything else. But bringing the CRP down will not relate into the desired anti-fibrotic effect. See, you're only handling one cytokine, right? And here there are multiple cytokines which are getting liberated, which are all combined, engaging with the neutrophils, with the T lymphocytes, and causing this anti-inflammatory process. So if you knock off something more fundamental than a cytokine, that is a B cell, which is itself liberating IL-12, IL-1, number of them, I think it is going to have a better effect.
Sure.
So contrary to standard thinking that rituximab takes a while to work, appreciate it takes a while to work, but it's some of the knocking of B cells takes place in 24 hours. But those B cells are only in the peripheral circulation. So that's the impact that we actually see. So I would say, let's meet again whenever you meet again, and let's see the follow-up of what the patient tells us, and then we'll come to know. But I elected to give rituximab. I did consider tocilizumab for sure, but then tocilizumab is going to only help one CRP, one interleukin 16, and that's not going to be enough to get a good impact on the lung.
Well, it probably isn't, but we've got to take aboard that tocilizumab does actually have a dramatic effect in the right subset of scleroderma patients. So it may be only one cytokine, but it's likely to be a rather pivotal cytokine in a subgroup of patients. So I'm glad you're coming back to reconsider it, shall we say.
Yes.
Oh, it's fascinating. I mean, I think
how you follow with rituximab? I mean, now you are given one dose.
yeah.
Yeah, so basically we follow the standard procedure. So today we have given 500 and 500, that is 1 gram. 14 days later, we'll give the third and the fourth dose, 500, 500. So there'll be the second gram. Then what I always do is do the B cell count before I give the rituximab. I do a IgG, IgA, IgM serum, and usually we'll have some 30 cells or more, before we give rituximab. If we were to do, which we do not do, CD19 cell count, say on day 2 or day 3, it'll be 0. And it will remain 0 for at least 4 months, 5 months, 6 months. And then the B cells in peripheral circulation will repopulate. Now we have 2 schools of thought. One school of thought is to go periodically every 6 months and give rituximab. The other school of thought is to wait for the B cells to repopulate in the peripheral circulation and then, hit another rituximab. And this can vary in a single patient from time to time. It can vary between patients quite enormously. So we don't know what is the truth between the two. But patients who have very aggressive disease, it may be worthwhile giving it every 6 months for 2 years or 3 years. That means that will be about 4 or 5 such cycles.
Stem cells, anything? Sanjeev, you're not keen on it, right?
No, well, stem cells has been a bit of a disaster in our experience. Only at CMC Vellore they had done a few patients. I think 1 or 2 have been done in PGI Chandigarh, but not happy with it. As much as Sujit, we are not happy with this lung transplant our patients are undergoing. We are not having good outcomes in our patients also.
In the well-selected patients, lung transplant is not a bad idea. But again, scleroderma, I agree with you. The centers are very big.
Yeah. So our autoimmune disease behave a little differently from those patients that you people see, who have got primary alveolitis.
Scleroderma and stem cells and lung transplant. Athol, a quick comment from you?
Transplant, I think the main problem is rejection due to reflux. And that actually takes transplant out for a lot of scleroderma patients. There are centers that do transplant scleroderma that use figures that are not bad figures, but I think they're being very rigorous in selecting a minority subgroup that don't have major esophageal disease. And so I think everyone's worried. Stem cell transplant, we've seldom resorted to, in part because trying to get it done takes time. And in a situation like this, you really have to have management that's more immediate and effective. It has moved into mainline management. Every review article mentions it as a possibility.
Yeah.
People actually
I
put
think that's it.
practice.
Yeah. Thank you. Thank you. Asmita, you
Yeah.
had some great discussions today, really.
Yeah.
Thank you.
Thank you. And the next meeting will be on 16th of May
Yes.
before we meet for Build in Kochi. Thank you so much.
Thanks, Sanjeev, for joining in.
Thank you. Thank you very much.
Thanks, Athol. Thank you.
Thank you, Bhavin sir,
Thank
for
you.
staying back.
I mean, come on, yeah, 37 minutes overboard.